link. Okay? All right.
No
I don't know if
countdown.
it doesn't do anything. I don't know what it does on your end, but for me it doesn't do anything different. Okay. So Ryan, you would like to go first?
I'll be the first casualty.
Okay. I'm going to turn my email off real quick because I seem to be getting a lot of those right now from students. And I don't want that noise to interrupt. Okay. I'm offline. And I will be taking notes while you're speaking, so if you see me writing, it's just because I'm doing part one of the evaluation, okay? All right,
Okay.
go ahead. I want all the speakers to be standing, and then you should stand away from the computer screen, so I should see you from the waist up. Okay.
Well, that's a little hard. The title of the speech is Why You Should Deadlift. Uh, it's pretty much it's a definitive reason for everyone to include this exercise into their workout regimen. It is the perfect exercise that you can do overall. The deadlift, it's one of the best exercises, like I said, that you can do. It makes you strong, lean, athletic, and confident. Everybody likes to be confident, especially when giving a speech. It inspires, motivates, and builds mental toughness. And simply put, deadlifts just make everything better. Have you ever wanted to kind of know a magic secret or to know a magic pill to give you the look and feels and just the confidence that you want? Well, there isn't one. If I could figure out that, I would be a millionaire and I wouldn't be giving a speech right now. I'd be probably somewhere on a beach where it's nice and warm. But I can give you the next best thing, and that's a step to get you to where you want to be. And it's to include deadlifts into your workout. The reason that telling you this is that for the past almost 20 years I've been working out. Doesn't look like it, but I've studied it. I've gone to school for it originally with kinesiology. My background through the military. I was a physical training instructor. It's one of those movements that you can apply to everything in life. Like I said before, the deadlift, it's the best exercise that can be performed. And today I'm just going to go ahead and I'm going to brief you on pretty much the benefits of why you should start deadlifting. Now, besides, just to look pretty, there's different reasons for deadlifting. Deadlifting teaches you an important skill, and that's just to have proper movement in your body, in your frame. And as I said before, deadlifts are the king of exercises because with anything, you work out to get lean. We're all trying to look better. So the simple, equation, more calories out, the more calories in, we get to look the way that we want. Now, with that said, deadlifting does this. It increases so much more movement. It causes you to use more components of your body than just isolating shoulders, arms, legs, back. By deadlifting, it also increases your flexibility, which will improve, physical performance in any of your athletic activities. Also, with more flexibility, you decrease the risk of injury by allowing your joints to move in a full range of motion. Another good thing about deadlifts is that if you fail on the lift, just let go of the bar. You don't have to worry about having, weight on your back when you do squats. If you're new to deadlifting, though, there's an easy way to do it. So the excuse is I've never done it isn't pliable. Use a hex bar. It's where you stand in between the weights. You become the center of the mass. And when you lift, the weight's evenly distributed, whereas a bar, it's more towards the front of you. Now, a lot of people will go ahead and say that they don't want to hurt themselves by deadlifting, or it's going to hurt my back. Compared to a typical ab exercise, the deadlift is a far superior than an actual ab movement. Because as I said before, it incorporates not only your abs, but your trunk as well. So it includes your front abdominal muscles all the way to your spinal erectors. Truth be told, people who would benefit the most from doing deadlifts are those who pretty much deem them dangerous. You know, it's those same people that say that deadlifts are dangerous that don't even know how to properly pick up their shoes. Because most people, when you bend over, you overarch your back, which causes your back and your vertebrae to stretch, which is more susceptible to give you injury and more likely to cause injury that you're trying to avoid. Also with the deadlift, it's a fundamental movement. From, like I said, from picking up your shoes, to even lugging and tugging on your luggage to get it into a car. It will make you more applicable in your daily movements. So, you know, to go ahead and just go back over why you should be doing deadlifts, is that there's no miracle pill. There's nothing that I can tell you that's going to be the exact answer to how to get in shape, to lose weight, to build more mass. But by giving you the knowledge and information on certain exercises and movements that make it easier for you to expand your frame from just, you know, arm curls and squats, you'll be able to improve your overall health. So that's why the deadlift is the best exercise that you can possibly perform. It makes you strong and lean and athletic, and as I said, confident. It builds that mental toughness, and simply put, deadlifts make everything better.
The end.
And now we make it bleed. I know. Now with the scribbles and notes, and it bleeds and.
Well done.
Oh, sorry, I had mine on mute, so you couldn't hear me. Okay, so now, good job. I want to open it up for any questions that anybody has for Ryan about his speech, or if you want to get deeper into the topic, you can.
Can you tell me exactly what deadlifting is?
Deadlifting, it's essentially bending over and picking something up. It's the easiest way to explain it is you step into a bar, you raise with your back flat, you control your weight, and as you lift up, you explode through your hips and raise the weight up, which it's essentially, to make it applicable, it's like bending over to pick up groceries, to pick up a baby, to pick up your shoes, like I said. A lot of people don't bend with their knees and, you know, lift with their knees. Everybody wants to tug and jerk with their back. And that's why the deadlift is the most fundamental exercise that a person can do, let alone, you know, everyone should do it, from kids to grannies.
Now, when you mean everybody, do you really mean everybody?
I mean everybody. There was actually a lady,
okay.
A 91-year-old lady who's attempting, before she turns 100, to be able to deadlift over 200 pounds.
Wow. It's impressive. So do you think pregnant women should deadlift?
I think pregnant women should deadlift.
Okay.
Because, I mean, you don't...
Yeah.
No, I was just going to say, you don't want to be sedentary, and then you just sit there and, you know, you have your peanut butter and crab cake cravings, and, you know, you're taking in all these calories. Like I said, you're putting all these calories in, and next thing you know, ooh, right, we're down a totally different road.
Yeah.
They usually say that if you could do it before you were pregnant, you can do it through your pregnancy.
Yeah.
That, I mean, don't pick it up at 8 months pregnant. You might break your water while you're doing it, but
right,
beforehand, you can continue to do it through as long as you're not having any problems.
Yeah, I took my one and only CrossFit class, and there was a woman who was 8.5 months pregnant, and she was doing box jumps, which is different than deadlift. But I thought that baby was going to come out of her because it was a lot. It was too. I had to leave because I was just like, this isn't safe. This isn't good. This is bad. It's going to end badly.
Well, I guess that's one way to have a C-section.
Right.
I mean, I'm not a subject expert. I have no clue how that whole.
Right. But it was
I'm an OB nurse.
Yeah. Should she be doing box jumps?
If she was doing it before, she can keep doing it.
It just seemed like so much impact. But anyways, okay, good. Any other questions?
No.
All right. So then we can move to the next speaker. See, was that painful? Ryan,
Absolutely.
it was?
Yes. Well,
To look
because
painful.
well, the way that my room's set up, like to stand up, it's really awkward.
Mm,
Because there's no way to balance my iPad without
right.
you looking at my waist and below. Um, so I kind of made an executive decision on that one to kind of just back up in the seat.
Yeah.
And it's real weird talking to a screen and not actual people because it's hard because I don't see everyone's reaction. I just see the avatar of people, so I don't know how to gauge it.
Yeah, yeah.
Which then you kind of start to stumble over words because you're looking at people and you're like, well, wait, because you can't read the audience, and that's kind of my go-to. That if I'm losing you, then I can spice it up or throw in, something different. And in between, just yeah, I didn't know how this was going to go, so that's why I wanted to go first. That way, it would be worse, buy everybody time, so they could see how not to do it, so that when they do it, they have a way better idea. Because that's one thing that I've learned is, just always be the guinea pig. You can't go completely wrong.
Yeah.
But just enough.
We appreciate it.
Yeah.
As long as it's like a 71, I'm good.
No, definitely there is that you can't use the audience to, improvise or that aspect of online or of public speaking is definitely diminished for the most part whenever you're speaking online, unless you have I can see everybody's reactions because on the computer they have everybody's live, but I understand what you're saying, you can't because the iPad version is different and that's fine. But yeah, that is definitely something to consider that would be difficult when speaking online. Unfortunately, this is the wave of the future.
Well, that, and I like to move around a lot. I'm like a kitten. I'm all nimble and bimbly. So being confined to a chair, just watching me, my hand movements, I'm always moving, tucking things. It's real awkward for me personally because I'm very expressive in movements.
Yeah. Okay.
And I wasn't going to stand on my chair and do a deadlift to give an idea of how to properly do one.
Might have been helpful for some of us.
Well, maybe I would have got bonus points for comedic action.
Yeah.
Visual. You could draw little stick figures on the back of your note card and show it to us later.
Yeah, yeah.
Make like a flip, or just flip it around and pull up a YouTube video.
That'd be good. That'd be good. All right, who's next?
Yeah, I'll just do it.
Okay. Thank you.
Hopefully my phone does not fall how I have it cropped.
Okay, if it does, we'll just resume once you pick it up.
Okay. Oh, I don't like that view. I'm gonna kneel down.
See what I mean? That's what I was talking about.
That's really far away, but I can't see my phone at all. All right.
You're good. We can see you.
Okay. Well, hi, my name is Danny Pearson. I do go by Danny. When you call me Danielle, I do feel like I'm in the principal's office, so Danny, please. I did my speech on heroin and the nationwide problem that it has become. It affects more than just Cincinnati is where I live. It affects the whole nation, and it affects more than just the heroin user. It affects their children, their family, their friends, us as the taxpayers, their unborn babies, the community, and the social services department. I personally work in OB float, which means I do labor and delivery, I do postpartum, and I do special care nursery, which is a step down from a full-blown NICU. We just don't do intubated kids. So on a daily basis, I see moms and or babies who are personally affected by the negative impact that heroin has had on our community. Why heroin, you might say? Why not cocaine anymore? Heroin has become our problem. I believe it tracks back to about 2000 when the Joint Commission Accreditation of Healthcare, also known as JCAHO, declared that pain was the fifth vital sign, and we must assess and treat pain accordingly, which sounds like a good thing, right? Shortly thereafter that, Medicare and Medicaid decided that they would only reimburse hospitals and doctors based on patient satisfaction. Okay, well, again, that sounds like a good idea. The problem became when patients were not satisfied when they were not treated for their pain. And then doctors had to dole out more pain pill prescriptions in order to keep their patients happy, whether they needed it or not. So small things led to more prescriptions, led to the doctors getting reimbursed and the hospitals getting reimbursed. That also led to a nationwide pain pill addiction. And when the pain pills run out, heroin is the next step. As declared by the Centers of Disease Control and Prevention, heroin became the next step for the opiate users of our nation. So how does this affect us? How does this affect me? I don't do heroin. Shouldn't be a problem, right? Well, most of us know somebody who knows somebody whose life has been affected by heroin. The families of these people have many issues to worry about now. They have to worry about financial, social, health care issues of their family members, and they have a daily understanding that anytime that phone rings, it could be their loved one who's overdosed. The children for the heroin users are usually placed in foster care or with other family members, so now we have to worry about taking care of their children for them. Taxpayers, we're paying all the medical bills. We're paying for rehab. We're paying for social services. We're paying for the Medicare and Medicaid in order to take care of these people. And then their unborn babies. There are many, many, many lasting effects on heroin use and unborn babies. The National Institute of Drug Abuse, show you my little thing here, got a little visual aid here, declared that birth defects, increased SIDS risk, behavioral issues, depression, learning disabilities, and growth restrictions were all issues that faced our unborn babies born to users of heroin. You might also ask, what does a baby who's been exposed to heroin look like? What do they act like? What kind of issues do we have taking care for these babies? Well, neonatal abstinence syndrome, I'm going to try to center this here for you, is displayed with blotchy, moldy skin, diarrhea, excessive crying, high-pitched crying, excessive sucking, fever, hyperactive reflexes, increased muscle tone, irritability, poor feeding, rapid breathing, seizures, sleep problems, slow waking, stuffy nose and sneezing, sweating, tremors, and vomiting. We score these babies in the special care nursery using a scoring called Finnegan scores. The NAS score sheet has these 21 symptoms that are most frequently observed in opiate-exposed infants. And based on how high they score or how many of these symptoms they are showing, we usually begin treating these babies with methadone. Other places use other drugs. We tend to stick with methadone. It's worked pretty well for us. If the baby is not treated with methadone, they can start having seizures, and they can have hypoxic brain injuries that lead to brain damage or death. So it's really imperative that we treat these babies. You can't just give them methadone and walk away. You have to taper them down. So if a baby is born, they come to us, and they're usually there for almost a month, weaning down off of methadone so that they do not die from being exposed to the heroin. So in conclusion, heroin is a big problem that affects us all, not just those who use heroin. Healthcare may have inadvertently led to and let this problem become a little bit bigger by exposing more patients to opiates who may not necessarily need them, because JCAHO and Medicare and Medicaid have tied pain medications into reimbursement. It is imperative that we educate our patients and make sure they know when is it appropriate to use a pain medication, that it is okay to use in certain situations, and how to make sure they do not become addicted. It's a problem that we need to address now, because all these babies that are being born, these are our future generation, and it is our responsibility to make sure that our future generation has the best chances it has. Thank you.
I had to unmute my thing. Any questions for Danielle?
Good job, Danielle. Very good job.
Thank you.
I do have a question.
Yeah.
So, do you have like any studies or research that shows though that the increased use of drug and particularly heroin, I think it was. Do you have anything that shows that that's the reason why of the increased drug use is because of increased pain management in healthcare?
Yeah. Well, there are a lot of places. The Center of Disease Control is one of them that had mentioned that, kind of linking it back to the overuse of prescription pain medications, and then linking it to, because it is an opiate, the easiest opiate to get on the streets is heroin.
That's really interesting.
Yep.
My sister used to work in the NIC unit, and she actually had to stop because she's aggressive kind of person. She would get into fights with the mothers who delivered babies who were addicted to heroin and everything like that, and because she couldn't handle it. Takes a very special person. So I commend you on your job and the ability to tolerate people who put others' lives at risk, especially such a small life.
Right. Thank you.
Yeah. Any other questions? All right, good job. Great topic.
With
Yeah, go ahead.
no, she probably said it, but it was just hard for me to hear.
Yeah.
With for the kids that are born, how many times is it taken by the parent, and injected for it to be a symptom for the child, or is it just kind of one and done, and then they're hooked? And at
It can
what
be one
stage
time.
of?
A lot of times what I hear from users, and I can't say I've done a lot of like book research on it, has been that heroin is like a one-time use addicted kind of thing. I have heard people say that the first time you use it is amazing. You feel the best you've ever felt. You never feel that way again. Every time you use after that, you're attempting to achieve that, but you never do again. That you feel like major poop if you don't have it on board, and you just feel normal with it on board, and you're always achieving that next high, that next that good feeling, and you never get that again. You have this extreme desire to achieve that, and it doesn't happen again. So I mean, to say if someone were to use it in the beginning of their pregnancy, the chances are they are going to continue through the rest of their pregnancy, which of course would lead to more likely harsher withdrawal symptoms on the baby. Whereas if the very first time she were to use it were 2 days before she delivered, and she'd never used it before that, which is again very unlikely, because at that point I've not seen anyone who's never used drugs before begin right before they deliver. It's usually a long-standing thing. But I mean, they still can have some degree of withdrawal. I guess it would make a difference on how much were in their symptom and how long they were exposed for. But typically you see withdrawal symptoms within about 72 hours from the last exposure. So if the mom used, then the baby used, and you'll start seeing those withdrawal symptoms in both mom and baby in about 72 hours.
And you actually answered the second part of my question is, doesn't matter what part of the time in pregnancy that's used. So you kind of answered the question without even knowing it.
Yeah. If they had used, because the baby will also withdraw from the methadone. So if mom is a heroin user, finds out that she's pregnant, and then goes to a clinic to seek help, they're going to put her on maintenance methadone to keep her from feeling that major crappy feeling. It just keeps her feeling normal, but then the baby has to wean off of that methadone. So the baby will withdraw, and mom would withdraw from the methadone itself.
Awesome.
Yeah. All right, great information.
Thank you.
All right, next speaker.
So I'll go next.
Okay, great.
All right.
Perfect.
Can you see me? Okay. So my name is Adele Kessler, and I'm going to be talking to you about hospice care and what are the goals of hospice care. So picture this. You come in to sit in your doctor's office. Your doctor comes in, solemn face, clipboard in hand, results in hand. 3 years of fighting, aggressive treatment, nausea, vomiting, pain, anxiety, sweating, and overall discomfort. And still, despite all of these treatments, you continue to be fighting a losing battle. So what are your options? We can stop treatment, and then we can decide whether or not it is that we want to just die alone at home without treatment, or do we want to continue treatment and perhaps die in the hospital, connected to tubes, ventilators, IVs, electrodes? Are there any options? Well, unfortunately, 100% of us are going to die. And so we are going to have to make that decision as to how it is that we are going to die. The HPNA, Hospice and Palliative Care, states that 10% or less of us are going to die a sudden death, meaning that we are going to die of a sudden heart attack or get in a car accident. Most of us are going to die from illness related to chronic illnesses, or we're going to wither away just because we're living longer and we've been able to eradicate most of our infectious diseases. So I've been a hospice nurse for the past 6 years. I've been certified in hospice and palliative care for the past 5 years, and I've helped several families to make decisions about the way it is that they want to die at end of life. So there are other options other than just dying in a hospital, fighting to the end, hooked up to IVs, having electrodes connected to you, having ventilators and tubes placed in you. Hospice care can help patients meet their needs at end of life. So I'm going to define what hospice care is, talk to you about some goals and services of hospice care, and then explain who exactly qualifies for hospice. So first of all, what is hospice care? Well, hospice is a modern-day movement in Western medicine. It was actually brought to us from Dame Cicely Saunders back in the 60s and 70s. And it started as a grassroots movement with volunteers being the whole staff to be able to help all of the patients. Well, it has grown. It is now a Medicare benefit, and it is for everyone that has a terminal diagnosis of 6 months or less. And it is able to provide services to them either in the home or in a freestanding hospice, as well as in nursing home facilities where they may work at as well. And the patients are able to receive this care from physicians as well as social workers, nurses, as well as other counselors. So then what is the goal of hospice? Well, the goal of hospice, according to Cubular and Heidrich 2006, states that the goal of hospice is to provide emotional, spiritual, social, financial needs of the terminally ill. And in most cases, those spiritual and emotional needs are going to be provided to us by bereavement counselors and chaplains. And those physical needs are going to be supported by the nurses and the physicians. But these team members work as a team, the interdisciplinary team, and they all collaborate to make sure that the goals of the patients are going to be met in the best way possible. So if you have a patient that wants to sit up at the dining room table and eat dinner, well, everyone on that team is going to help to make sure that that patient is able to sit at the dining room table and eat. And other therapies are also going to be involved to be able to help make this possible. And so then, who is appropriate for hospice care? Well, we talked a little bit about it, but you need to have a terminal diagnosis, of course, and then 2 physicians need to give you the prognosis of 6 months or less. You also need to want to be able to stop curative treatments. So if you're a cancer patient and you're receiving chemotherapy, you're going to need to want to stop doing that. Most of our patients are also going to be DNRCC, or do not resuscitate comfort care only, meaning that they will not receive CPR if their heart were to stop. And then they also want to have their symptoms managed. But there are patients that meet these qualifications. They have a prognosis of 6 months or less, and they have a terminal diagnosis, but they still don't qualify for hospice care. And those patients would be the ones who want to continue curative treatment despite the fact that the doctor has said there's nothing else we can do. Or maybe they want to be resuscitated. And it doesn't mean that they never will qualify for hospice, but at that current time, they're not going to qualify. So they may need to come back at a later time. So then, hospice care is an option that patients can choose at end of life to determine care. And hospice is for symptom management as well as holistic care. Just to reiterate, there are other options to dying other than dying in a hospital fighting on tubes, strips, machines. Hospice care can help patients meet their needs at end of life. So we're going to end with a quote from Dame Cicely Saunders. "You matter because you are, and you matter to the last moment of your life," from TED Talks in 2011. Thank you.
Good job.
Thank you.
All right. Questions for Adele?
Nope, they're good.
I'm good.
All right. So, Adele, tell me a little bit more about your job. Like, do you go to the homes of the people that are on hospice? Is it strictly at the hospital?
So the hospice that I work for, they provide services in the home. They also provide it at a freestanding hospice. So they have beds, and then they also go to facilities like nursing homes or sometimes hospitals.
All right. Does it just depend on the patient, what they want, or is it based on their needs?
It's based on their needs. Wherever they live at, we'll go to them.
Got it. Wonderful. That also takes a special person. I commend you. It's got to be hard. All right. So, Jeremy.
Yes.
The last one.
All right. Can everybody hear me?
Mm-hmm.
I don't know. For some reason, it's not switching over to my screen when I talk.
It is for me.
Oh, okay. Well, I apologize. I'm going to have to, I'm not going to be able to stand up. My basement doesn't have the best lighting, so if I stand up, I'm going to be right in the light and you won't be able to see me at all. So I'll back up and do the best I can. All right.
Okay.
So today I want to talk to everybody about heart disease. At the end of this, I would like to have all of you be able to describe the 3 main causes of heart disease and 3 most, or I should say best ways to combat this. It's one of the leading causes of death in the United States every year, and it's very important to know what causes it and how we can prevent it for both ourselves and our loved ones. So I'd just like you all to take a second and imagine you're laying on a cold stainless steel table. There's bright lights over you. Your eyes are taped shut. Surgeons bend over you. He has a scalpel. It's cutting into your skin all the way down to the bone. Breaks out a saw. Cuts through your sternum. Spreads your chest so he can access your heart. And take away the veins and replace them with grafts out of your legs. You wake up in an unfamiliar room. You're biting, gagging on a tube. It's in your mouth. Your hands are restrained so you don't pull this tube out, because most likely if you pull this tube out, you won't be able to breathe on your own because you're still under the effects of anesthesia. It's a scary situation when you wake up, even though you know what you're going in for most of the time. It's just not something you expect, no matter how much we educate you on it. So according to the Centers for Disease Control in 2015, heart disease is the leading cause of death in the United States. This preventable disease accounts for 610,000 deaths annually in the United States, which also accounts for 25% of the deaths in the United States throughout the year. So for the past 2 years, I've worked on a cardiovascular intensive care unit where I get to care for these patients on a daily basis. I get to help settle them when they come up from surgery and take care of them post-op through their whole stay until they get discharged, and I get to see these people walk out the door, not ever knowing that they just received open heart surgery. So many of these people, like I said, they have modifiable risk factors. Some just have hereditary risks, and they are very healthy adults, and they come in with blockages. But like I said, for the most part, we can educate and prevent and help a lot of this. Such factors like obesity and tobacco use are two of the biggest causes. It's sad to see these patients. Some don't have the best knowledge base, and they get to suffer, or they have to suffer, I should say, from these diseases that could be preventable. So with this growing problem that we have, it's important to know how we can combat these diseases. And today I'm going to discuss with you the causes, symptoms, and treatments for heart disease. So first I'd like to talk about the causes of heart disease. Several of these are modifiable in some degree, some more so than others. But the leading causes are smoking, high cholesterol, high blood pressure, and diabetes. The National Institute of Health, and that's according to them in 2014. According to the CDC in 2015, 40% or 47% of all Americans have at least one of these modifiable risk factors. That's quite a bit. Any one of us five, it's 2 to 3 of the 5 of us could have this risk factor. So it's quite alarming. And we may know a family member that has this also. So smoking is the main modifiable risk factor. What happens with smoking is it hardens your arteries and the vessels of your heart. Not only the heart, but other arteries that extend throughout your body, into your legs, and that lead to other vessels as well and other organs. And this is all because of the chemicals contained within the tobacco. This is per the National Institute of Health in 2011. Your vessels, they'll harden. They're not as pliable. They cause an increase in blood pressure, narrowing because of the buildup of plaque throughout your arteries. This is called atherosclerosis. It's just fat and plaques that build up in our vessels. No matter what we do or how healthy we eat, we all have some extent of this in our vessels. And obviously with those risk factors, some more than others. Consistent high blood pressure, the way we eat, and the other activities that we do can cause high blood pressure. And according to the American Heart Association, this causes a damage to the inner lining of our vessels. And what happens when the inner lining of our vessels get damaged, they tear, and it creates pockets and places for this plaque to build up, causing increased buildup throughout different areas in our vessels. There was a study conducted in the UK that tested A1C, hemoglobin A1C. Now, some of you don't know what hemoglobin A1C is. Hemoglobin is carried. It's what our oxygen combines to in our red blood cells. Well, when there's a lot of blood, or a lot of glucose in our vessel or in our blood, the excess likes to find a buddy to hang on to. So it decides to go to the hemoglobin. So when you're testing people, this test allows them to go over a several month span to see how they eat and how their glucose tolerance is. Most people, normal people, non-diabetics, 4 to 6%. I've seen people 8-10% that are poorly controlled diabetics. Some people more. So this just increases our risk of heart disease. Like I said, diets high in sugar promote fat storage and cause these damages and buildups to our vessels in our heart. And they also affect how our heart pumps to our other organs, our kidneys, our brain, and so on. And also, according to the American Heart Association in 2014, one study showed that people who consumed about 20% of their diet calories in sugar, they were about 38% higher for developing heart disease. And these, like I said earlier, these damaged vessels and hardened vessels become easily occluded by the free-flowing plaque and blood clots, which can clog your arteries and cause a heart attack. Just the other day, we had a patient come in that was going in for a procedure totally unrelated to the heart, and they ended up having a massive heart attack in the OR, and they ended up getting transferred to our floor for emergent open heart surgery. So it can happen to anybody. But with so many problems, has to be some kind of symptoms that we can learn from and figure out what causes this. Several physiological factors that are important to know about heart disease. Chest pain is a big one. Heart's not getting enough blood to the right areas, so muscle's dying, and it's going to cause heart pain or chest pain. So it's very very important to recognize that. Sometimes it may only be while you're walking. Sometimes it may be while you're at rest. So it's important, if you're having chest pain, obviously to call 911 and get the correct form of treatment. This pain may go down to your jaw, left arm, and also women present differently than men. Sometimes women might just have weakness. So symptoms are very different and complex for everybody. Excuse me. Because your heart is not effectively pumping when there's blockages, you may experience shortness of breath. Your heart's not able to pump enough blood to your lungs to become oxygenated to flow to all your other organs in your body. And you can also notice decreased sensation in other extremities as well. Hands and feet may become cold, discoloration, all different signs of blockages in different vessels other than in your heart. But like I said, it all goes back to these main things and these main causes. It's also important to realize that these symptoms come from, like I said, the narrowing throughout your body and decreased blood flow. But even though there are so many causes and symptoms, it's still very preventable. We just have to be strict in the things we do and how we educate to help this. Like I said, smoking is the #1 modifiable risk factor, so quitting smoking is the easiest way to do this. There's plenty of ways out there to quit, plenty of programs, patches, gums, plenty of people willing to help. Some people smoke a pack a day for 20 years, other people 2 packs or more. Each one just increases your risk throughout the line. Exercise, very important. I know today everybody is so much busier running around, kids, activities. We don't give ourselves the time for exercise that we need, but it's important to get in what you can. They say 30 to 60 minutes, 3 to 5 times a week is best for this. I know we don't all have this in our schedule, but it's best to get it in where you can. Anything is better than nothing. doesn't have to be high intensity. It could be walking up and down the steps in your house, taking a couple laps around the local mall. Anything can help reduce blood pressure, cholesterol, diabetes. Prevents it all. Also, your diet. We like processed fast foods. They're easily accessible and they're cheap, so we tend to hang on to these things and consume them on a regular basis. But consuming diets that are high in sugars and fats, they greatly decrease or increase the amount of fat and plaque buildup. So cutting those out of our diets will greatly reduce those risks as well. And not just taking one of these interventions, but combining them and exercising and eating right. Getting enough sleep is another one. Are all things that build up and help us decrease these risks of this terrible disease that is preventable. So heart disease is a silent killer. Affects millions of Americans, causes heart disease and a lot of other complications with other organs if not caught early and treated correctly. So it's very difficult seeing a loved one suffer from something that we could have helped them prevent. But serious and the symptoms, I mean, it can kill you. So then nobody wants that. So hope that through this education we can help prevent this disease. So, thank you.
Good job. Good job. Questions for Jeremy?
So I got a question.
Yeah.
Jeremy, so it sounds like you're really knowledgeable about heart disease. Do you, through your research, do you find that an increase of blood sugar or an increased A1C actually increases your risk for heart disease more so than increased cholesterol levels or lipid levels?
I mean, everything is everything correlates to that. I mean, over the span of time, everything's reversible, obviously with the exercise and diet, and unfortunately sometimes we have to rely on medicines for that. But somewhere in here I had that through the American Heart Association there was a correlation. Yeah, between the 20% of their daily calories, 38% risk higher for developing heart disease. When at least 20% of their diet was consumed in calories from sugars. So there is a correlation. I mean, it's a fifth.
Mm-hmm. How about salt or sodium intake?
Sodium intake, so that'll increase blood pressure. And like I said, the damaging to the vessels. Sodium, water likes to follow sodium. So increase tone in your vessels, increase blood pressure, and it's more for your heart to pump as well. So.
Okay. Any other questions? No? Good job, everybody. I learned a lot today.
Yeah, if anyone has any webcam issues, if they have an iPhone, it's a good backup.
Yeah, yes, definitely. I will be posting that announcement. Use iPhone. It works. Yeah. Do you guys have any questions for me? Any confusion in the class that I can clarify now? It's easier than clarifying via email or even posting on the Q&A board. I think it helps to talk face-to-face.
Are there going to be any more?
Oh. Okay, let's do one at a time.
Go ahead, Jeremy.
No, you go ahead.
All right. Are there going to be any more speeches since this was kind of the first one and we were all kind of thrown in? Okay, so I was thrown in the fire. I didn't know what to expect. I don't know about anybody else. And I completely bombed it. So I was just wondering if there was going to be any redeeming speeches that we'll be able to do like this. That way, you know, forewarning.
Okay, so we have one more speech. It's the persuasive speech.
Mm-hmm.
Okay, and it's also worth 100 points.
Is it going to be given like this on Google Hangouts?
I need to look because I can't remember. I think it's VoiceThread, but I might be wrong. Like I said, this semester everything has changed. So the only one that used to be live was the ceremonial speech, and we don't do that one anymore. Which was my favorite speech, by the way.
Where can I thought I read that these were going to be uploaded somewhere that we can review them later when we do our critiques. Where can we find them at?
So they will be posted on my Google Hangout page, and they will also be posted on my YouTube page. I will send you the link to that. But you should be able to search me on YouTube, SMA234, before it posts immediately. So as soon as I end this broadcast, it will be available on my YouTube, and it's public.
And we critique each other on a voice thread then?
Mm-hmm. So you're going to record your feedback to your peer.
Okay. And does that need to be just audio or video as well?
It only has to be audio. It would be great if you included video, but you don't. Why I say it would be great is because if you have specific feedback about how they could include visual aid, they could use verbal or nonverbal text to match their verbal text, you could show them how to do that via video. So like you could remember a statement that they said and then restate it and use nonverbal communication to match it. Just show them how to do it.
Okay.
Which would be really great feedback for them. It is the persuasive speech is via VoiceThread.
Okay, so we'll never use Google Hangouts again.
Mm-mm.
Thankfully.
All right, I'll be deleting this app once we're done.
All right. Sorry it was painful. Hopefully the technology gets a little bit easier. And I'm just praying that Skype includes the video format because Skype is so easy to use. And the group calls now are free. So before I used to do group calls on Skype, it cost money for me, which was fine because it was easy. It was an easy platform for everybody to use. But Google Hangouts, there's just too many steps involved. And I understand it's frustrating. I get it. And I'm sorry. But it's something that the school wants us to use. So
it's not bad. It's just if someone said earlier, I don't remember who, but possibly like a dry run to kind of get an idea for the technology and to see what we're stepping into.
Right. Which that means that you need to schedule it with somebody else because I can't schedule dry runs with everybody in the class plus this. It's very hard to find schedules that match.
Well, it's not even that, but if to forewarn coming classes, hey, it's kind of totally different than probably anything you've used. Check it out prior. Maybe almost when you break down the groups like we did, to have us meet prior to get used to the technology instead of just kind of stumbling and fumbling and getting it to go kind of how we did today.
Yeah, no, I will definitely suggest that. Whether or not people do it is another thing. But yeah, I definitely agree. If you can log on 30 minutes before and try to start a Google Hangout with your group, that would be very helpful.
We were actually trying that when you called in.
Yeah, I know. That's what I heard, which was excellent. I hope others take advantage of that and do it as well. But yeah, I understand it's a confusing technology. And what I don't like about it is if you don't have a Google account, then you are forced to start one, where that's another email that you have to keep track of. Because you have to start a Gmail, right?
Mm-hmm. Yeah.
Yeah, so with Skype, I mean, yeah, you start an account, but it's not as big of an account, right? You don't have the YouTube associated with it, the email associated with it. Who else knows what else is associated with Google? Google is so giant. So that's why I like Skype better. I think it's just a matter of time that it will have the record it feature.
Okay.
But unfortunately, you'll be done with this class by then. So irrelevant, right?
That's not
But but at the same time, it seems like OU is using Google Hangouts for more online classes, so you will encounter this technology in future classes if you still have classes with eCampus.
3 more.
Yeah, so, and I know it's going to be included in that Comms 1000 if you haven't taken it already. So at least then you'll have training, proper training, because you are supposed to take Comms 1000 before you take my class, which is teaching you how to use Google Hangouts.
Oh.
Yeah, so I think this semester a lot of students got in my class that has never taken that class, but it's a prereq for this class. So I see the chaos and the confusion, and I'm like, but you're supposed to take this class before you take my class. So it's just, I don't know how everybody got enrolled without taking that class first, but it is a prereq for Comms 1030. And I think that it helps. I can tell the students who have taken it, they know how to use the technology because they had a semester's worth of training.
Yeah, that would be helpful.
Yeah. So don't hate me. Talk to your advisor about how did I get into this class without taking the other one first.
Well, at least you know, I think I'm the only one that's taken 2 of your classes at one time.
Right. So you get double dose of this technology. Yeah. I think I have one more student who's in.
Are we going to be doing Google Hangout for 2060 or no?
No. Just VoiceThread, which is in itself another sometimes chaos. Well, you're very good at VoiceThread for hating it. You always have bells and whistles in yours, so you do really good.
It's the 6 kids running around in the background with bells and whistles. It's not intentional.
Yeah. I enjoy VoiceThread because for me, it's better than reading a bunch of discussion posts. I like to just press play and listen to it. And I think that might be the case for you guys as well. When you have to respond to others, instead of reading a bunch of posts, you can listen. You can multitask, essentially. So hopefully you're seeing the benefits of it, and it's not just a nuisance. Maybe not.
No, it is. I like it so much better than doing the discussion boards that we write. Yeah. It's just, I think you can improvise a little bit more. It's not so stringent. It's just a little bit more enjoyable, but it's a lot of work up front. So there's a payoff. There's difference, positives and negatives to both. So do you feel like we're open? I mean, is this the big one, and it's kind of down here from here?
Yeah. I think if you once you're done with the informative speech, the persuasive speech is so much easier because you can first of all you can adapt your informative speech into your persuasive speech. So you can use the same topic and make it persuasive. You've also done the research. You know how to get the sources. So then you'll just take the feedback that I give you for your informative speech and make positive improvements for the persuasive speech. And it's also not live, so you can practice it. You can record it as many times as possible. You'll upload the one that you are the most happiest with. So this is the hardest speech. The informative speech is definitely the hardest. Persuasive speech, if you start all over again and use a new topic, that's going to be a little bit more challenging because you're digging into the research again. You're finding new sources. You're cross-checking them. So I do recommend if you're comfortable with it and you like it.
Okay.
Yeah.
All right.
So it's downhill from here.
Good. Like to hear that.
Yeah. So good work, and it was nice seeing everybody.
All right. Are we good? Good.
Yeah. Any other questions?
No. I appreciate it.
Nope.
I'm going to go.
Okay, great. We'll see you guys later. Have a good night.
Thank you.
Thanks.
Bye.
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 So when we bomb this one, like I did,
Stop it.
we'll be able to redeem ourselves to where I can just get above a 70 so I don't have to pay back my school. Because I completely skipped a whole section of my speech and I was lost, and like I said, it threw me off, so I just wanted to double check that.
Yeah. So I'm going to end this broadcast and then we can continue talking, okay?